the next next hour, we're going to be talking about the history of the healthcare reform. Before we do that, I just there's a couple new people here with us today sitting on the side, and I think it's always good for us to know who's in the building. So if you can just do quick introductions.
Jeff Hochberg, Vermont retail druggist, pharmacy.
Mike Fisher, healthcare advocate.
Okay.
Sarah Teachout, government relations for Blue Cross and Blue Shield of Vermont.
Wayne Mullins, UVM intern for Representative Pohen and Representative Dolan.
Great, thank you. All right, and I think we're having Ameren join us. Are you doing it from there or from there? Okay, great. Yeah, come down and then you can introduce yourself.
Good morning, everyone. For the record, Ameren Abergele Legislative Council. If for some reason you can't hear me very well, please let me know and I will turn up the volume, so to speak.
Thank you. And just for our purposes, do you want to hold questions? Will you take questions throughout?
Happy to take questions throughout. I also have with me Jen Carby, our Chief Counsel. I am new to the healthcare portfolio. Jen has previously served in the role that I am currently in, so she has some historical knowledge of the programs that I'm going to be talking about briefly. So she's here for backup as needed, but we're happy to take questions along the way.
Great, thank you.
I haven't met before.
Oh, okay, let's do introductions of the committee. Thank you for that. Since some of us haven't met Ameren.
Representative Brock Peterson, Rutland District 2.
Leslie Goldman, WIN number 3, which is the Bells Falls area.
Morning.
Representative Rebecca from Winooski. You know me because I've given you a bunch of work.
Aha!
I'm Papa McFarland and I represent Barrytown and parts of Williamstown.
Lori Houghton, Essex Junction.
Alyssa Black, Northern Essex.
Alan DeMar of Edithsburg, Montgomery.
Joe Andriano from the Addison Rutland District.
Bobby Farley's Rubio, Caledonia 1, which is Barnett, Reigate, and Waterford.
All right, so I'm going to share my screen to do a PowerPoint presentation. And hopefully can do this. Okay, so. Great. Oh, it's so funny. I can't see what you're seeing. I guess I can see what you're saying. Okay. So this is Vermont, a brief history of healthcare reform. And how do I turn that? There we go. All right. So first, some background facts. Okay, we're looking at over time from the year 2000 up to 2009 and then to 2020. So you see the population has increased from around 608,000 to 643,000 over the 20-year period. I know Nolan gave you an overview sort of some, healthcare 101 and maybe looked at some similar numbers previously. So we're looking at healthcare spending and how that has changed over time from $2.3 billion in 2000 up into $6.37 billion in 2020. Looking at the money spent per capita and then percentage of state GDP. So if you have any more questions about this slide, I encourage you to talk to Nolan at the Joint Fiscal Office because he will have more information on what these numbers mean.
And he was in yesterday, just so you know, and and he'll be back again, so.
Great. So you'll see also, this might be another aspect that you covered yesterday with Nolan, but you'll see the change in population of people who are in private insurance versus Medicaid, Medicare, military, uninsured over this 20 to 21 year period of time. So if there aren't any questions. So Vermont has a long history of coverage, quality, and cost control initiatives. We're going to go way back here to the 1940s, right, when we have reforms dating as far back as those years. The legislature has passed many healthcare reform bills over the years, some making small or incremental changes, some modifying existing programs, and some establishing significant new initiatives. So this presentation is going to begin with the 1990s and only focus on those significant and specific healthcare reform initiatives that happened over this past 30-year period.
This is a question I don't expect you to answer, but I'm curious, maybe just a reference to a resource. I'm curious, what healthcare might have looked like before the 1940s, that they felt the need to restart reforming it there. I'm wondering if there might be any books or articles that you might suggest on that. You could even email me later, it's perfectly fine, but it's just something I'm curious about.
Okay, I will say that predates my time.
Yeah.
But I will see what we can find.
What humors you might have? Yeah.
That's a great question. It'd be interesting just to know that.
So major reforms in the 1990s. First, Act 160 of 1992 was an unsuccessful push for universal care program and single payer. There was the creation of the Healthcare Authority in 1992, which was a 3-member administrative body tasked with responsibility for ensuring universal access and containing healthcare costs. And you'll see a lot of the same sort of themes come up as we move through these slides. So this entity existed for about 4 years before it became part of the Department of Banking, Insurance, Securities, and Healthcare Administration, which was known as BISHCA, which is currently the much of this is currently the Department of Financial Regulation, although there are small pieces that moved over to the Green Mountain Care Board. Next, you have Dr. Dinosaur, which is an eligibility expansion for children. Currently through the Medicaid waiver, I believe Dr. Dinosaur existed prior to the Medicaid waiver where it currently sits, but it was implemented in the late 1980s, early 1990s. And this increased eligibility up to 300% of the federal poverty level in the mid 1990s. So Dr. Dinosaur has been around for quite a number of years. The Vermont Health Access Plan, eligibility expansion for coverage for low-income uninsured adults through the Medicaid waiver, also included a prescription component, and then eligibility is expanded to 195% federal poverty level for parents and caretakers of eligible children. And this was a program that ended in 2014.
A question here. The first one, eligibility expansion for coverage of low-income uninsured adults, and that's through Medicaid waiver. It would seem that the purpose of Medicaid is to care for these folks. What expansion was needed to cover them? I've always wondered that. It seems like, if you're low income or have no insurance, that Medicaid's there. Was there something that happened then, or?
Going to phone a friend.
Sure. Jen Carvey, Legislative Counsel. So at the time, the Medicaid eligibility threshold, income eligibility was much lower, and it was not available to childless adults. And so this was a population that didn't necessarily have access to private insurance, but wasn't eligible for Medicaid. So through the waiver.
Okay, so it closed that gap and made it.
It closed a lot of that gap.
Yeah.
And the reason it ended in 2014 is that's when the ACA, the Affordable Care Act provisions with the exchange and all of the provisions built into that took effect. So the VHAP program
became unnecessary.
Didn't have a place anymore.
Okay.
And correct me if I'm wrong, so we're all clear. So the Medicaid guidelines come from the federal government unless we have a waiver, which allows us to expand criteria.
Right. There's the federal program, and then our waiver allows us additional flexibility beyond that to expand eligibility and benefits.
Great.
Thank you.
Major reforms in the 2000s, H524 in 2005, which was vetoed by Governor Douglas, but this created Green Mountain Health, which was a publicly funded healthcare coverage for uninsured residents with a limited benefit that would expand over time to a universal complete benefit. This was financed by health effort tax on wages.
Can I ask what that means? What's a health effort tax?
And we'd have to look into that. It predates all of our time here. I don't know if the healthcare advocate remembers because he was.
It's a tax.
But what do you have to pay? What do I have to go running? What effort do I have?
I don't know if that's a priority. We can certainly look into it.
Well, it's not
I think it's fine. Yeah.
You put it out there, so.
Yeah.
Yes, that was,
But it was vetoed by the governor and never went into practice.
Oh, is that, I was wondering if it was overruled, it wasn't overruled.
It was never put into practice.
Okay, so it didn't.
It didn't matter, okay.
Next is Catamount Health, initially passed in Act 191 of 2006, but was later amended several times. It was implemented in 2007 and ended in 2014, which again was the beginning of the Affordable Care Act. This created a new health insurance product offered by Blue Cross Vermont and MVP. It was a state subsidized premium assistance program and a state subsidy for employer-sponsored insurance, if eligible, and if more cost-effective to the state. And this was financed by employer assessment and a portion of the cigarette tax revenue. So other notable reforms in the 2000s, VFARM, which is a Medicare Part D wraparound prescription coverage for low-income Vermonters. Blueprint for Health, which I'm sure you'll hear more about soon, which is a chronic conditions pilot that began back, oh gosh, I'm actually not sure what date it began. It began in session law and it was later codified and expanded. So then the Health Information Technology Fund was created. And there was the establishment of the Healthcare Reform Commission, which existed from 2006 to 2011, and then the ACO pilot project.
I'm going to stop you there real quick. Mike?
I just want to point out that the health employer assessment lives on, the healthcare fund contribution assessment is what it's called. And it's one that I think Nolan has done. Nolan has a presentation on.
Great.
Something the constituents may raise.
Okay, great. Go ahead, Joe.
What does ACO stand for?
Accountable Care Organization.
Thanks.
Yeah.
And we'll learn more about those.
Yeah, you'll know all about it.
Thank you. I'm trying to avoid using acronyms, but they pop out sometimes.
Yes, they do. For all of us.
Oops, I skipped ahead instead of behind. What happened? I'm sorry.
Technology.
Technology. All right, let me share again. Let's see. What happened?
Take your time.
The pressure.
No pressure. No pressure.
Press that delete button.
Sometimes I think we should have a page in every room who can handle the technology
That's right.
for us. That's who I go to, is my 14-year-old son, who says, Mom, I showed you how to do this already.
Okay, that's where I was. All right, let's try this again. Okay, let's get back to where we were. Okay, so now we're on to major reforms in the 2010s. So there was the SHOW study, which was in Act 128 of 2010. The legislature hired a consultant, Dr. William Shou. I'm not sure if I'm pronouncing that correctly. Shou, thank you. To design 3 healthcare system options, single payer, public option, and at least one other. There was the Green Mountain Care Act 48 of 2011. This would have created universal and unified single payer healthcare system. Then there was the Vermont Health Benefit Exchange, also in Act 48 of 2011, but in other legislation as well. This is known as Vermont Health Connect, which offers qualified health plans, also known as QHPs. This was initially designed also to be the platform to support Green Mountain Care, but later it is only for Vermont Health Connect. This merged individual and small group markets and was only in place to purchase qualified health plans. It also provides premium assistance and cost-sharing subsidies in addition to federal subsidies for individuals up to 300% federal poverty level.
So Amber, can I just stop you there?
Yes.
Real quick, just to make sure. So this is what we talked about yesterday with Nolan. This is where you go as an individual or small group to buy health insurance on the what we call Vermont Health Exchange. And Blue Cross Blue Shield and MVP are the insurance companies that are available through that exchange. And there is no, remember that I think Nolan showed us yesterday, there is a Green Mountain Care card still, and that's the insurance card for people who are on Medicaid, but there is not Green Mountain Care per se as a health insurance open to the public, or to the, correct me if I'm wrong.
Right, that was gonna be the single payer and it.
Right, it did not happen. Representative Black? Or Alyssa, I'm going
This is
with first names.
actually kind of a dumb question, but would have created universal unified healthcare system?
No.
It passed Act 48. Why don't we have that? It's not funded.
Right, because the
Because we don't have enough money
financing
to do
study
it.
came back and it was never, there were several steps that had to be triggers to actually implement it. So it is still on the statute books. It's in 33 VSA Chapter 18, Subchapter 1, if you are interested.
I was gonna say, Joe wants that. Can you say that again, Howard?
So it's 33 VSA Chapter 18, Subchapter 1.
Is that the whole healthcare chapter? Is there, that if we wanted to?
Right, oh, Subchapter 2, I'm sorry, Subchapter 1 is the exchange.
Sorry, so if we wanted to look at the healthcare chapter, would it be
That chapter has the exchange and the individual and small group plans in Subchapter 1. Subchapter 2 is what would have been set up for Green Mountain Care, and it includes the triggers for implementation and a number of other provisions. But there's also several other chapters, and in fact, a lot of Title 18 itself is all health stuff. So there isn't really one place to go to look at the whole healthcare, all of the healthcare provisions. Insurance mostly is in Title 8, a bunch of health stuff in Title 18, some in Title 33.
So did that answer your question?
Yeah, so basically we have single payer healthcare, we just don't pay for it.
Well,
We don't
we
have
just
it.
have
It was
it.
never
It was never
implemented. So there are a
implemented.
number of provisions necessary for implementation, would have included things like enacting the taxes to pay for it,
right.
the General Assembly
Okay.
appropriating funds to pay for it. There's some others. We can certainly look at that, the
Right.
trigger language if you want. But so you have a program, the shell of a program in the books, and it has never been implemented.
Okay, thank you.
I'm just going to say the governor at the time declined to advance it because it was such a heavy lift financially. And if you're interested, if you Google it, there was a lot of around.
There's a really good interview with him at the Kennedy Center with Governor Shumlin right after, and they were interviewing him about the failure of it. And it's very interesting to watch. So if you Google that, you'll find it.
Great. Joe?
And you said that there's different healthcare statutes in different places. Might it be possible to send us like a list, like broadly where to find, you said there's some in 8, some in 18, some in I think 33 you said. Even if it's, I'm not asking for every statute about healthcare, but just like broadly where we could look if we want to find healthcare stuff.
Sure.
Great, thank you.
Thanks, Amron.
So other notable reforms, we have the adoption of the 14 principles for reforming healthcare in Vermont, is in Act 48. The creation of the Green Mountain Care Board, which included transfer of some duties from the Healthcare Administration that we talked about earlier that was at BISHCA that became Department of Financial Regulation over to the Green Mountain Care Board. And then the all-payer model and accountable care organizations in Act 113 of 2016. You'll be hearing more about that in the coming weeks. Current reforms, so healthcare delivery integration, once again, talking about accountable care organization programs. There was the Medicaid Next Generation program, which began in 2017. Vermont Medicare ACO program began in 2018 with an existing federal Medicare program. Vermont modifications began in 2019. Then there were some commercial ACO programs where Blue Cross Blue Shield and small self-funded programs first participated beginning in 2018. And you also have Blueprint for Health, integration at a community level with those accountable care organization programs. So again, you'll hear about much of this in more detail over the next week or two. Then there's the all-payer ACO model agreement, which sets goals for limiting healthcare cost growth closer to Vermont economic growth, maintaining and improving the quality of care in Vermont, and focusing on population health goals around chronic disease, suicide, and substance use disorders.
Representative Peterson?
Yeah, this all reminds me, now let's tell a brief story here. I went to work in 1978 for New England Telephone Company, which became NYNEX, which became Bell Atlantic, which became Verizon, which became Fairpoint, which is now consolidated. And every one, there was little pieces kept. When I see this, I'm wondering, what did we keep from all this past stuff? Is there a way to, this is where the big ball of yarn comes from. There's so much stuff that we've done in the past 30 years. Is some of that still in place as well as the new initiatives? Or is it all the stuff that since what was the last reforms? 2017? Is everything previous to that gone?
No.
It is.
No,
it is not.
It is not. You'll see there are certain threads that have followed, certain programs that have continued on.
Yeah.
And then there's been, as you say, sort of an evolution of pieces of these reforms.
This is where in my learning of healthcare, I get very confused with the intersection of all these things that happened 30 years ago, some of them, and what we're doing now. Where does one stop and one end, and who works for who? If I was an employee, I think I would be mystified by who I work for, because you've got so many different things. And I'm wondering, is there a way to kind of have a timeline thing of what's still in place now in healthcare so we could understand it? Some sort of, I don't know, a structured block diagram or something, so we can figure out just what's in place so that we can reform it.
So I'm gonna, if you don't mind, Ameren, I'm gonna step in on that. So I think you bring up a really great point, and you give a really good example of all the changes that a telephone company made. And the point in doing this presentation is all the changes and all the things we've tried to implement in Vermont. Some have been successful and some have not.
Right.
And so when we sit at this table and we know we still have a lot of work ahead of us, we can think about, well, we've tried that in the past, so why didn't it work? Could we do something different? Or to your point, what do we have today that we can work to make more successful? So I think instead of a timeline, what I would like to do is rely on the committee as we're hearing from, all the various people we hear from, to keep what you're saying in our mind. And remember to say, right, so the all payer accountable care model agreement, which started in 2016, went for 5 years. And we are now hearing a presentation next week as we're working with the federal government on a new accountable care organization. And I think when we model, all payer model, and when we have those conversations, I think we can talk to the Agency of Human Services, Healthcare Reform, and Green Mountain Care Board, who are all involved in that process, and say, okay, well, what worked with the model in the last 5 years, and what are we trying to make better now with this next model that we're hoping to move forward with? Blueprint for Health, same thing. That's been around forever, and it's progressed, and it's really a valuable piece of our primary care system. And so we'll have Blueprint in to talk about, well, what's been successful and what can we build on from that? So, and then they'll, like Green Mountain Care, single payer. It didn't work for many, many reasons in the past, right? So what can we do to ensure that at least the principles of Act 48 are getting put into place as we make decisions? And as Topper is very good at reminding us, causing unintended consequences to people. So does that work as a way to help kind of build on what we've done as we go along?
Well, the danger, as far as I can see it here, is making reform on something that's already there. I mean, looking at this, I don't know what's actually there now, because there's been so much tried.
Right. Right. And I understand that. And I think the key is we're not going to get that from this presentation.
No,
We're going
no.
to get that from all the
I understand.
agencies that come in and talk to us, or organizations about, and people who sit and talk to us will be very open about what is and isn't working.
Yeah.
I have no doubt about that.
Yep.
That's why we love Ledge Council so much, because they know.
Say that again?
That's why we love Ledge Council so much, because they know.
That's right.
Representative Goldman?
I think that's really interesting, and I think the question that came up for me are, what are we still responsible to?
That's right.
So Act 48, Act 48, principles but never funded. So does that mean we're still obligated to those principles? And I don't understand how that works. That's confusing to me. Maybe we should be. I'm not saying yes or no. I'm just trying to understand that.
Right.
Yeah, what do we have to be held accountable to from all of this?
Well, I think we have to be accountable to understand what is and isn't working. So whether or not we're accountable specifically to those Act 48 principles, right? We are accountable to helping Vermonters have affordable, accessible healthcare today. That's who we're accountable to. And with everything that's out there that's been done or will be done, that's our guiding principle. And what do we need to learn, enhance, or put to the side?
So what's not working now? We've got all these things and
That's right, the $1 million question. And everyone who comes before us will have a different perspective on what is or isn't working. And I think if you talk to your constituents, they're going to have a perspective on what is or isn't
it'll be
working.
different in every
And it will be different in every area of the state. That's a really good point. Geography is huge in our state because we have we have Chittenden County, and then we have a lot of rural areas, and we have larger cities in the south as well. I think it's going to be what type of insurance you have. So are you on Medicaid, Medicare, commercial, uninsured, underinsured? Is it, what are your own health issues? And is it pharmacies? Is it prescription drugs is your biggest issue? So it is sometimes, you bang your head on the table because there's so much, and we just have to be clear. And I think what we're going to do this next hour when we're done with this will help us. What's going to guide us in our decisions and make sure we're listening to as many people as we can listen to. I think that's really, really important. Did you have anything to add, or Alyssa?
No.
Alyssa? Oh, is the...
That was the end of
Okay.
slides.
Okay.
I just have a little basic question. What is meant by all payer?
Do you want me to do that?
Yes, or good.
And do you want to start, and then you want to do the legal piece of it?
Sure.
Why did I ask that question? Come on.
A can of worms, I guess.
It's really as simple a question as you think it is. The all-payer and the all-payer model is really looking at having all of the payers over whom the state has regulatory authority paying for healthcare using the same or similar methodology. And it's so there's a framework set out in statute, but the all-payer aspect of it is a little bit of a misnomer because we don't have authority over self-funded employer-sponsored coverage. But other than that, and we don't have authority over things like TRICARE, but other than that, trying to get the payers doing things in a consistent way.
And other people, in more layman's terms, other people will say it's moving from a fixed fee for service, right, to more of a capitated model where we're paying to keep people healthy. So Medicaid is they're one payer. And what they do is they work with our accountable care organization, which is OneCare, and they look at the risk of their portfolio and say, we are going to provide, and I am making up these numbers, $1 million to care for this Medicaid population. And we're going to distribute that based on your hospital system or whatever. And you are now to keep Vermonters healthy and give them care with that lump sum money. And then at the end, there's a whole reconciliation process. So we've been moving this way with the all-payer model since 2016. We don't have authority over Medicare either. So that, and they really drive it. So there's Medicaid, and then commercial. Well, here, not all commercial are involved yet. There's still various levels that are paying fee for service. So it's a mix, but the concept is moving towards what Jen said.
Okay, I get it. I think I get it now. And I remember the history of that move just as a regular citizen listening to the news.
Exactly. And this will, everything we're talking about this week will be repeated over and over and over again as we, dive into legislation or programs. Not everything we do in here is a piece of legislation, right? We'll look at programs and hear about things, provide oversight. It'll all be repeated over and over again.
So am I properly understanding, because I had the same question, but I don't think I understand yet. Is that to say that an all-payer model is essentially to eliminate differences in the way that different insurers might cover different things? Because it's all regulated the same? I'm not.
So are you asking, would all providers cover colonoscopies the same?
Yeah, whatever it might be.
No, it's more it's more at the top level on how we're paying for whatever services that community hospital area provides to their community.
Prospectively.
Prospectively, yes. So, yes.
So it's perspective look at how we are going to create a healthy community.
Exactly.
Got it.
Right.
And can I just add, I think we're talking a lot about how care is paid for, but I think a couple of us have kind of skirted around the issue of how people are going to get better. And so we haven't really talked about what I think is at the center of it is the triple or quadruple aim of healthcare, which is what the all-payer really kind of gets at. And this fiscal thing that we're talking about is just one component of that. And I think, we talked about it, Joe and I have talked offline about the RBA model that a lot of the AHS folks.
What's RBA?
Acronym. Results-based accountability. So looking at, outcomes and having a way to measure how well we're doing. And I think when they bring in their budgets and stuff, we'll start hearing more about that. But I think, looking at these financial aspects is looking at, are we reducing the costs of what it takes to deliver quality care? And having those measurement-based outcomes is, are people really getting better? And so I think, I don't know, for me, as I'm learning all of this about, the back end and the payers, I'm also keeping in mind, the fact that there are other prongs to the stool on this, and it's, there are also measurements tied to these fiscal impacts.
I'm sorry, Mari's first.
I think another way to look at it, or an additional aspect of it, is our healthcare system was incentivized it was fee for service. It still is in some areas. And so part of the system was incentivized to just keep doing more procedures and keep doing more of this and more of that. And there was duplicative things happening and waste. So by trying to get more of our system on the same page with the same measurements, the same public health goals, especially around some chronic health conditions, getting away from fee for service and using a prospective model so you get paid ahead of time. And you have to, whatever the healthcare institution is, largely hospitals, you have to stay within that prospective payment. And you're incentivized to do that instead of incentivized to do more procedures or
tests or
whatever that maybe are not necessary.
So all payer is an incentivization model to encourage providers to not just do those things which will make them more money, such as more colonoscopies, but rather to do those things which will make people and communities healthier, and by using results-based measurements, that's how we measure whether or not that's working. Is that a basic summary of it? We can get more deeper at some other time. I'm just.
Yeah, so that's a basic summary. I will say we're going to have next week on the agenda will be an overview of the all-payer model as it exists today. We are currently in negotiations for the next iteration of the all-payer model, and we'll have an update after the background on what the state is hoping to achieve with the federal government going forward. So I would say let's hold any more discussion on that till we have the experts in.
Great, thank you.
That'd be great.
I just wanted to point out that if you took a look at the Vermont Department of Health presentation this morning from AHS, they have some slides on the results-based accountability. It was on cholesterol and hypertension or whatever. So it'll give you a little window into that. And they also have that on their website.
Great, thanks.
Any other questions or thoughts or comments?
I would just make one comment, and if I'm wrong, correct me. Also, the providers, if they go over the amount of money that they've been allotted to provide the services, they have to eat it.
Yes, so there is some risk base that goes with each contract that is had between OneCare and the people involved, the providers, provider network, whatever, it's usually the hospital at the hospital level. And so, we can talk about that next week, yes. But if they save money, they get to keep it.
They get to keep it.
And then hopefully reinvest it in the community.
Right.
Or staff.
Well, if they, their entire medical community, it could be a next level.
Yeah.
Lots of questions, but I'll wait till next week.
Yeah, I know, and I hate to put you off, but
It's okay.
it's better to ask with the experts in the, so when the one's negotiating. Amryn, anything else or? Nope. Jen, anything else? Great. All right, we are ending early every time this morning, which is great. So we will be back at 11 and we will be working on a mission statement for the committee. And I just want to be clear in my expectations. When we work as a group to wordsmith a document, it can get a little chaotic. So I'm going to, with Topper's help and Alyssa's help, we're going to do what we can as a group. And it may be that we then say, okay, who wants to work as a little subcommittee to refine it, talk about it, and then bring something back to the committee. I do not want to talk about where an and or a comma should be in this discussion. So this is going to be high level, what should be our guiding principles? And then, like I said, we'll probably turn it over to some of you who want to volunteer and do more. So, great.